So good morning, everyone. Lovely to see that we have some people in the audience today. We would like to start this session on arthroscopy and the TFCC. We have a slight change in the program. We're starting off with Dr. Mustafa Mahmoud from Egypt, so please get on the stage. Sorry about that, Dr. Choi. You will shortly be able to go up.
Good morning. I'm presenting my talk about all through only working 6-hour portal repair of the superficial tear of the TFCC. And it's all about palmar 1B tears. It's a EWAS class 1. We use the 3-4 portal as the only working at the viewing portal and working portal through 6-hour. We use 2 PDS sutures through outside end technique, and we insert the loaded 21 gauge hypodermic needle to engage the deep part of the superficial part of the TFCC, just palmar to the tear, and then exiting the suture from the 6-hour portal, exiting the first limb of the suture. And then we withdraw the needle without getting outside the skin, redirecting the tip of the needle in the subcutaneous tissue, superficial to the capsule, to exit through the 6-hour portal to retrieve the second limb of the suture. And this creates a vertical suture to apply a tension perpendicular to the tear. We apply 2 or 3 sutures according to the size of the tear, and then we examine the tension of the sutures, apply a second and third sutures according to the size, and then we apply locking suture and supination after releasing of the weight. We use this technique in 28 patients, average age of 32-year age, and we in 26 of them, they return back to the pre-injury level and improved VAS and DASH scoring. And we had 2 complications, appearance of instability in after 1 year and persistent pain in 1 patient. So this technique is not a new technique. It's just a simple outside-in technique using 6-hour portals as the only working portal. We apply 2 or 3 subcutaneous extra capsular knots perpendicular to the tear to apply maximum compression, and no need for other portals, either 6U, DRUJ, accessory 6R, and no loop sutures, lasso, or meniscal set. Yeah, thank you.
Thank you very much, Dr. Mahmoud. As we all know, the knots on the PDS-20 suture get quite thick. Did you have any considerations with the sutures impinging on the ECU or the subsheath?
Usually the subcutaneous sutures are irritant for some time, a few weeks, and then irritation just disappears completely.
Okay, and what is your post-operative management on these?
We immobilize for 3 weeks just for pain, and not for the integrity of the suture, and we allow gentle motions for 3 more weeks, and then we allow full loading after that.
After 6 weeks?
Yes.
Yeah. Thank you very much, Dr. Mahmoud. Very nice technique. Thank you. Sorry, we had a question here. Sanj, Dr. Mahmoud, please come up. Dr. Kakar from the Mayo Clinic had a question.
Thank you, Dr. Hagert. I enjoyed your paper a lot. I just wanted to ask you, I've done this technique as well, and before I tie the suture, I'm always worried that I might catch the extensor of the small finger. And so I open it up a little bit, and some of the times I'm actually through the extensor and I've had to release that. So in your experience, can you tell me about that? Because that structure definitely is at risk.
We are always trying to keep as very close to the ECU tendon. We 6-hour portal just proximal to it, not going too far radial. And keeping on the radial side of the ECU, it keeps you on the strong subsheath and prevents uniform tethering the digit minimi tendon. Of course, in large tears, you are subject to entangle this tendon, of course.
Thank you very much, Dr. Mahmoud. We welcome to the podium Dr. Choi, who will present his paper on changes in the morphology of the TFCC on MR arthrography related to disruption of ulnar foveal attachment. Please,
Thank you,
Dr.
Chairman. Good morning, everyone. My topic is about the changes in the morphology of the TFCC on MRA related disruption of the ulnar foveal attachment. We have no COI. Among the various components of TFCC, the two radial-ulnar ligaments span the ulnar corners of the distal radius and form an apical attachment on the ulnar fovea. This proximal ligamentous component acts as a primary stabilizer of the distal radial joint. Disruption of each foveal attachment may require surgical repair. Despite of the importance of the fovea tears, the diagnosis remains challenging. High-resolution MRI and MR arthrography provide better assessment for the TFCC tear, but the reported sensitivity, specificity, and accuracy was very widely among the studies. The arthroscopy hook test can be used to assess foveal insertion of the TFCC, and changes in the morphology after rupture of the PLC have not been investigated in detail. In some patients, PLC showed distally prolapse patterns, like a mountaintop appearance. We hypothesized that TFCC fovea disruption would cause curvature change of the PLC, resulting in a more distally prolapsed pattern. From 2014 to 2018, we retrospectively reviewed patients who received MRI subsequent wrist arthroscopic examination. Through this exclusion process, total 134 lists were included in this study. To quantifying the amount of the distal prolapse of the TFCC, we measured height to length ratio of the PLC. In addition, we measured the TFC angle as described in a previous imaging study. All lists received the arthroscopic hook test as a confirmatory exam, and the patients were accordingly divided into fovea tear group and intact fovea group. We assessed variables that could contribute to individual difference in TFC morphology, such as ulnar variance, degenerative TFCC canthal tear, and presence of ulnar stelloid fragments. Radiologic parameters and assessed variables were compared between two groups. Logistic regression analysis was performed to control for potential confounders. Total 101 lists were divided in fovea tear group, and 33 lists were in fovea intact group. Univariate analysis showed that the HLR only was significantly greater in fovea tear group. On multivariate logistic regression analysis, the estimated cutoff value of the ROC curve for HLR was 41%. Within the TFC fovea tear group, 25 lists showed a complete tear on arthroscopy, and the remaining 76 showed only a proximal tear. There was no significant difference in HLR and TFCA between two subgroups. There were several previous studies on the changes in the TFC morphology. The possible causes of mountaintop shape might be listed as follows. With subgroup analysis, we suspected the HLR reflects the effect of the deep fiber rather than a superficial fiber. Limitations. We did not evaluate the effect on TFCC morphology of the intraarticular injection of contrast agent for MR arthrography. Conclusion. A distally prolapsed morphology of a proximal ligament component, so-called mountaintop sign, could be used as an additional predictor of the TFC fovea tear. Thank you. 감사합니다.
Any questions from the audience? Well, thank you, Dr. Choi. We all appreciate how difficult it is to tell the diagnosis of a foveal tear. So anything that can aid us is very helpful. Thank you for that. So my question is, if you have a patient with ulnar-sided wrist pain, no DRUJ instability, but you see the mountaintop on MRI, what do you do?
If the pain is origin from the instability, do you mean the treatment?
Yes.
Yeah. When the patient, if the patient persists pain with the instability, I will repair with the transosseous repair technique.
Okay, thank you very much. And so have you changed your treatment algorithm in your clinic based on the mountaintop findings that you have?
Yeah. In Korea, in our institute, usually check the MRA instead of the MRI. But with these studies, we confirmed the reliability of the mountaintop sign in MRA. So we want this sign applied to the MRI.
And when you do your MRA, do you always standardize the position that the patient is placed in? Is there a wrist coil used or the Superman position, or how do you know how they're... Yeah, the Superman?
Yeah.
Okay.
Yeah.
Excellent. Thank you very much.
Thank you.
So we welcome to the podium Dr. Egi from Japan, discussing prognostic factors for simultaneous arthroscopic repair of deep and superficial TFC portions. Please.
Thank you, Chairman. Good morning. Yes, it is my pleasure to give you a presentation on prognostic factor for simultaneous arthroscopic repair of deep and superficial TFCC portion for outside class 2 tear, prospective 1-year follow-up study. I have no financial relationships to disclose. Deep portion of TFCC plays a special role as a primary stabilizer of DRUJ. Detachment of the portion from the ulnar fovea induces huge instability. And superficial portion of TFCC attached to the ulnar styloid more contributes than deep portion to stabilize the DRUJ in pronated position. Therefore, I think it would be reasonable to repair not only the deep, but superficial as well. So I hypothesize that simultaneous arthroscopic repair with both TFCC portion will be effective for outside class 2 tear. This prospective 1-year follow-up study examined postoperative outcomes in patients who underwent the procedure. I also analyzed the patient's characteristics to derive the postoperative prognostic factors. I conducted this study, which included 33 patients, all patients diagnosed by physical examination, MRI, and DRG arthroscopy. Mean age at the time of the procedure was 31 years. Mean ulnar variance was plus 1.1 millimeter on radiographs. I conducted this study, all patients underwent arthroscopic anatomical TFCC repair using 2 radiocopper and 2 dorsal DRG polars. The portion repair was transosseous fashion to the ulnar fovea using a 2-0 fiber wire suture. Superficial portion repair was performed by outside-in technique to the capsule around the ulnar styloid using 3-0 PDS sutures. Postoperative immobilization periods were 4 weeks. Data were collected using Megerle score, quick dash score, and grip strength every 3 months until 1 year prospectively. Then I analyzed relationship between postoperative outcomes and prognostic factors. I defined the cases into 2 groups, good or poor. Poor outcomes group required additional surgery, Mayo score was 80 points or less, while quick dash score was 25 points or more at 1 year after operation. The various items shown on the right were analyzed. Regarding the Mayo risk score, the preoperative average of 61 points increased to most postoperative average of 94 at year. It improved significantly after 6 months postoperatively. Concerning the quick dash score, the preoperative average of 33 points improved to postoperative average 6 at year. It improved significantly after 6 months postoperatively. Regarding the grip strength, the preoperative average of 72% improved significantly to postoperative average of 91% at 9 months. In terms of the prognostic factors, the outcomes are good in 85% and 15% were poor. Only 2 factors, ulnar plus variance and workers' compensation users, were detected as poor prognostic factors. I'd like to share with you about my case presentation. This patient was a 20-year-old woman who had a sprain. I performed this procedure 10 months after the injury. Before the operation, it was impossible to work for pain, and the clinical scores were poor. MRI recognized foveal detachment. Pain disappeared in 1 year after the operation. Returned to work. Mayo and DASH scores became excellent. MRI also allows good insertion into the ulnar fovea and styloid. For the ulnar side repair of TFCC, it is desirable to reconstruct with a structure close to the original anatomy. From the anatomical study in 2017, the topography became clear. My technique has been done before that publication, but both deep and superficial fibers are reasonable to reconstruct the footprint of TFCC at the distal ulna using arthroscopic guidance. Considering the fact that outcomes were excellent, this procedure is recommended for the patients with outside class 2 tear. There were a few reports shown on the left concerning the prognostic factor of a TFCC lesion. In my reference, there was no article focusing on the foveal lesion using arthroscopic transosseous repair. The poor prognostic factors from this study were ulnar plus variance and workers' compensation. In such cases, some measures will be necessary. For example, use the ulnar recession together or try to solve the problem of works injury early. Conclusion. This arthroscopic anatomical reconstructive procedure is recommended for the patients with TFCC tears associated with DRG instability. The prognostic factor are ulnar plus variance workers' compensation. Thank you for your attention.
Thank you very much, Dr. Egi. That is a beautiful presentation of an arthroscopic technique that no doubt requires quite a high skill of surgical experience. So you mentioned that you do this now in all patients who have an ATSE class 2. And in the ATSE class 2, it entails a DRUJ instability, but not always of the superficial fibers. So if you have a patient with only a foveal disruption, not the superficial portion disrupted, would you still do this?
Thank you for your question. I do transosseous foveal repair, the case of detachment, but you say no superficial layer rupture. I don't do that.
Okay, excellent. You also mentioned very distinctly that the ulnar variance was one of the important prognostic factors. Now, we all see ulnar variance in our patients. How much of a positive ulnar variance do you believe is important to not do this procedure?
Oh, good question. Thank you. Now, in my opinion, zero variance is appropriate, but plus 2 is normal variance including. So in my case, plus 3 millimeter, over 3 millimeter, I now do analyzation such as arthroscopic wafer or ulnar shortening osteotomy associated.
Thank you for clearing that up. That's because I always find that hard in my patients to decide when should you do an arthroscopic wafer, etc. Mm-hmm. Do we have any questions from the audience on this nice paper? All right, we thank you very much, Dr.
Thank you.
Egi.
So the next speaker will be Dr. Vahagwankar from India, and he's gonna tell us about the concealed TFCC tears and what to do about them.
Thank you, Chairpersons, and good morning, ladies and gentlemen. I'm going to talk about a cohort of patients that we see in clinical practice that poses a diagnostic and a therapeutic dilemma when they have a normal reported MRI, but you clinically suspect a TFCC tear. So we all know about the background of TFCC tears. I need not belabor too much on this, but like I said, I'm going to focus on the cohort where MRI is unequivocal or maybe misleading. So we all know that it is an important investigation, and it is critical to have technical optimization, and 3T does make a difference. And just a case in point, this is a 1.5 Tesla MRI picture, but we could not find anything on the MRI, so we had to repeat the MRI, and you could see the TFCC tear being put into evidence out here. So this is a 32-year-old right-hand dominant patient who came to our clinic with wrist pain, and he also had ulnar-sided wrist pain, but did not have instability. And then when we asked for an MRI, the report was that there was an essentially normal TFC without any injury. And since the pain persisted in this patient, we went ahead with surgery to and after resecting the ganglion, we then found that there was a TFCC tear after resection of the scar tissue. So a lot of times what we find is that there is scar tissue that we fail to recognize, and the MRI is just a picture where we are unable to diagnose these lesions, especially in chronic injuries. There is scar tissue formation that may mask the tear. And then when we put an arthroscope in, it kind of changes the perspective when you're looking at it live, and the ability to diagnose and treat these injuries is enhanced. Again, a point in case, this MRI was reported to be normal without any injury to the TFCC. And then when you put your scope in and you resect the scar tissue, you find that there is a tear. So the different types of tears can be diagnosed and can be treated appropriately. And as you remove the scar tissue, you will be able to put these tears into evidence and treat them as indicated. This is a typical case where you don't have much of rocket science to diagnose the injury. Depending upon what you find, standard setup, you treat these injuries as in when indicated. So the point of this paper is to again highlight that there is a cohort of patients that are a diagnostic dilemma. You know clinically that there may be a TFCC tear. The MRI is reported to be normal. It poses a challenge for convincing the patient that you do have an injury, and this requires treatment. However, with the advent of arthroscopy, we find that these neglected or missed cases can be treated with good outcomes. So MRI is an important diagnostic modality, no doubt about it, but having a high index of suspicion and patients who fail to respond to a reasonable trial period do qualify for an arthroscopic evaluation and treatment, and this is now certainly the technique of choice for many disorders of the wrist joint, especially tears that are missed on the MRI imaging. Thank you very much. Thank you.
Thank you. Any questions from the floor?
I have a question, please. Sorry. I've seen that you suggested to have several contacts with the radiologists and other guys. And what about the evaluation of preoperative and intraoperative stability of the distal radial joint? You show during the...
I beg your pardon, and I understand. The question is?
The question is, do you think that the intraoperative evaluation of the stability of the distal radial joint is better than before?
I would think so, yes. We always check the patient under anesthesia because when you're looking at it in clinic, there's guarding. It may not be as evident, especially the instability. They may have pain, especially in provocative testing, but if the pain is severe, they may not be very cooperative. So we do explain and counsel the patient that we're evaluating under anesthesia, so preoperative evaluation does play a very important role in my opinion.
Of course, thanks.
So what is the role of MRI in your clinic? So who does the reading? Do you look at the pictures yourself and make up your own mind? Do you even look at them at all?
Yes.
Does it change your routine, or how long are you waiting? Like, say, if somebody has like acute wrist pain, acute ulnar-sided wrist pain, so what's your algorithm here?
Yeah. So an MRI for us is not a eureka moment. It's a clinical diagnosis that you already made. The MRI is just an adjunct to what you're suspecting, at times even to find out if there is any additional pathology that you may have missed on clinical diagnosis, other lesions than the one that you're focusing on. And we always have a dialogue with the radiologist in our center when we talk back and forth. When we give a referral letter, we call them up and tell them that this is the patient. And again, like I said, this is a small cohort of patients where the diagnosis may be missed. A large majority do have a finding that is reported, but for those which are not reported, we have a dilemma. That's where we counsel and we proceed with arthroscopy in these cases. Thank you.
Any more questions? All right.
Thank you
very much.
Thank you.
Next speaker will be Dr. Almonacid from Chile, and he's going to tell us something about the evaluation and management of TFCC injuries. Please go ahead.
Good morning, everyone. We have no conflicts of interest to disclose. We are presenting evaluation and management of TFCC injuries. These are one of the most common ligament injuries of the wrist, commonly associated with pain and instability, and with frequent surgical treatment. In the initial approach, we have many provocative maneuvers and different options of match exams, and of course the alternative of arthroscopy evaluation. The initial treatment is usually conservative with immobilization and physical therapy, and we have the option of surgery, open or arthroscopic when it's needed. In this context, we want to present our arthroscopic findings from patients who require surgical treatment over the TFCC, to a classification of the TFCC injuries. And additionally, we correlated these findings with the preoperative physical and MRI examinations. For that, we ran this retrospective study from January 2015 until July 2018 with 107 wrists in 105 patients. We consider patients with DRG instability and ulnar pain, ulnar impaction syndrome and ulnar pain alone, who required treatment over the TFCC. Patients with distal radial fracture were excluded of this study, and all patients were initially treated conservatively. We consider the presence of a positive foveal sign and ballonment test, the report of 1.5 Tesla MRI examinations, and of course the arthroscopic findings to the radiocarpal portals. All of these injuries were classified according to Palmer's and Atsey classifications. And what we found 129 injuries with 78.2 traumatic injuries. The most common types were types 1B with 51.9% of the injuries, and type 2A with 15.5% of the injuries. And most of the type 1B injuries were class 2 and 3 of, according to Atsey, meaning they had a foveal detachment. We also found 20% of combined injuries, mostly in the DRG instability group with an 86% of the cases, and the most common combination was type 1B plus 1A injuries. In the group analysis, we found first in the DRUJ instability group, most of the injuries were traumatic with 91% of the injuries, and the most common type was type 1B with 72%. And in the impaction syndrome group, we found the number of patients with traumatic and degenerative injuries was similar with 52 and 48% of the injuries. And the most common type of injuries were 2A and 1B. The foveal sign was positive in 88% of the patients, and the development tends only in the 52%. But when we consider only patients with type 1B injuries, this went up to 89%. We only have access to 31 complete MRI radiological reports. Only the 48% was had positive findings, and only the 20% of those was correct. So, in conclusion, surgical treatment was mostly indicated in patients with DRUJ instability and ulnar impaction syndrome. Most of the injuries treated were traumatic, and the most common type was 1B. We found a high percentage of combined injuries, 20%, especially in the DRUJ instability group. In this group, most of the injuries were traumatic. On the other hand, we found a high percentage of degenerative injuries in the ulnar impaction syndrome group. The foveal sign was highly suggestive of TFCC injury and development test of proximal detachment. And finally, this 1.5 Tesla MRI examination was not really useful in the preoperative evaluation of these patients. Thank you.
Thank you very much. Questions? So, how do you make the diagnosis of DRUJ instability?
Clinically. Usually, we evaluate the patients in the excuse me. When we have a patient with this problem, we usually evaluate the instability, proven with the development test how the DRUJ act, only clinically.
And the same question as before, so do you do that beforehand or while surgery?
Excuse me?
Do you do that before surgery or?
Before surgery.
In surgery?
Yeah.
Okay. More questions? Then please go ahead.
Thank you. In what percentage of patients did you have a positive clinical blotment test and a negative foveal sign? So in the, I'd say, isolated foveal subgroup, because that is a problem surgically, is a missed foveal sign.
Yes, the patient, we had this instability in the DRUJ. They usually have pain in the DRUJ too. So most of the patients, maybe the 90% of them, had a foveal sign too.
Yeah, but that's my question: is what percentage did not have a foveal sign? Because I find that the foveal sign is sometimes negative with the, I'd say, second subgroup, and that is a problem. How do you manage that? If you just go arthroscopically, you're going to miss those cases.
Excuse me, maybe I am not understanding the question. Can you repeat the question, please?
My question is, sometimes with the, I'd say, second group where there's an isolated foveal detachment, the arthroscopic assessment is falsely negative. So do you have any advice in how to find those cases and not to miss those cases in fixing them arthroscopically?
Well, I think your question is about how to evaluate the foveal detachment in the arthroscopic evaluation, yeah? Well, we usually use the classic test for evaluate the proximal attachment of the TFCC. The classic test is the hook test. Now we are using lesser known tests like the needle test or the suction test. But if we have doubt about that, maybe we consider the use of the distal radioulnar portal.
So how often would you do a DRUJ assessment rather than a radiocarpal assessment?
It's not common.
All right. No more questions. So thank you very much.
Okay, thank you.
So the next speaker will be Dr. Kakar from the Mayo Clinic, and he's going to tell us something about the ulnotricutal split tears.
Thank you very much, Mr. and Mrs. Chairman. It's an honor to be here today. I'd like to present our work and especially acknowledge the co-authors and also my mentor, Dick Berger. These are our disclosures which aren't really relevant to this presentation. So just a little bit in terms of the anatomy, remember that the ulna is the fixed unit of the forearm and everything rotates around this. And when you think of stability, 20% is bony and 80% is soft tissue. Now there's a myriad of different soft tissue restraints. A simple mnemonic here is Rupert, starting from radius all the way through these attachments. And what we're going to be talking about, the ulnar carpal ligament, primarily the UT ligament. We'll start off with a case. So this is a patient of mine, a baseball player, unable to play, especially had pain with twisting and insupination. As we've talked about the importance of the clinical exam, the DRUJ was stable, but was point tender over the fovea. So I think it's important to rule out DRUJ instability. So in terms of the examination, we've just discussed about the foveal sign that was described by Tay and Berger. And essentially, as we all know, using the tip of the index finger, if we just go dorsal to the FCU and push into this area, you'll see the sensitivity and specificity is actually pretty high for this test. So in terms of the x-rays, these were invariably negative, and the MRI was suggestive of something going on in the ulnar carpal joint. Just very quickly before I move on, I just want to acknowledge this work, really, this is the brainchild of Mark Garcia-Elias, which talks about the four-leaf clover algorithm, that when you have a patient with ulnar-sided wrist pain, essentially ask 4 key questions, namely, is there a bony problem, a cartilage problem, what is the quality like of the static stabilizers, and what is the quality of the dynamic stabilizers, and go through that checklist. In these patients of the case that I just mentioned, it was a UT ligament split tear that we repaired arthroscopically. So the hypothesis of this study is actually how do these patients do in terms of their long-term functional sequelae. So we look back just under a decade of all of the patients treated with this, looking at numerous outcome measures, and we had 228 wrists. You can see the division here. Follow-up was just under a year. So interestingly, just under a third of all patients had some form of treatment before that they were referred to us for ulnar-sided wrist pain, but they continued to have pain and hence were referred in or seen. And in terms of surgical outcomes, a very broad statement, you can see how important, how improved their Mayo risk scores were from 56 to 82. When you break this down in terms of the visual analog score, you can see pain went down from 6 to a 1.4. Mayo risk score improved from 56 to 82, and 81% of the patients were satisfied. I think it's important to remember the four-leaf clover algorithm that I mentioned, that you have to address all ulnar wrist pain. And in about 10% of these patients, they had other pathologies except for a UT ligament split tear, ranging from TFCC pathology, ECU, or ulnar impaction. So when you break down these cohorts into those patients that had a UT split tear and those that had other pathologies, the take-home message is that you have to address both, and the patients otherwise did well. But not everybody did well. You can see that our complication rate was about 8.3%. What was the main complication? Some patients had continuous pain, dysesthesia of the dorsal-sensory branch of the ulnar nerve that eventually resolved, and superficial infection. So limitations, obviously it's a single institution study, retrospective, performed by a high volume of surgeons of subspecialty training. But in terms of the outcomes, I think the conclusion is that the improvement was in the Mayo risk score. You can see from 52 to 86, 83% good to excellent results, an improvement in terms of pain, but not range of motion. Thank you very much.
One question. You speak about of the split lesion and the other lesion around the ulnocarpal ligament. You didn't talk about of the detachment of the ulnocarpal ligament from the lunate and the triquetrum. Did you find it?
Yes, so these were taken out of that analysis because I think it's a different animal, that one. This was just literally a split tear, but as you said, they can be detached off the carpus, and I think when you break those out of that, there's a different animal.
Thank you, Dr. Kakara. I enjoyed that very much. And I find that this is something that I see quite often in tennis players. Do you agree on that?
Yes.
With that swing that they do and the curve on the ball, etc. And as you know, tennis players, they are eager to get back on the court. So if you have a patient, a tennis player, that comes to you with this type of suspected injury, would you treat them conservatively to begin with, or would you take them straight to surgery?
Were you looking at my patients last week, Elizabeth?
Yeah.
So, no, it's a great question. And I think for me, you know, it's interesting. In general, I'm conservative in nature. And so I will try conservative measures. But I've actually found in the tennis player in particular with the double-handed backhand, these patients are hard to get back non-operatively. I've had some, but if you actually had to sort of equate who gets back and who doesn't, I think surgery in general I've found helps them get back quicker. But I tell them honestly, with the tennis player specifically, 6 months. I think it's important to treat their expectations. Now, if you get them back earlier, then that's fine. But they can be difficult to treat.
Thank you.
Thank you.
Okay, thank you very much. So now we move on. We move on, ask to the Dr. Sims from Germany to talk about immobilization after TFCC operation.
Good morning. Thank you, chairpersons, for letting me speak here. Today the theme is a bit different that I have, the immobilization after TFC surgery, so the main thing is about bracing. Regardless of the method of treatment, be it surgically or conservatively, stress or overload of the TFCC should be prevented, and you should have an appropriate brace for that. What we do is, at our clinic, post-operative care, the wrist is immobilized in a TFCC brace, 3 weeks approximately, no flexion, no extension. After that, successively more extension and flexion. And what we have seen that after reinsertion, we had a success rate of about 94%. The healing process is 3 weeks without limitation of, is a limitation of pronation and supination. After that, successive increase of the movement. And the good thing is with the brace we use, when you remove the handrest, you can get more extension and flexion with the brace. What we do is, of course, movement without strain and successively resuming of the normal functions and the load bearing. Here is the brace itself, which the fact I actually wanted to come to. It's a pre-manufactured brace. It's not customized, and that is very important because actually, to be honest, everybody can do it, and that's extremely important in the clinic. And the survey we did was we had overall 24 patients, average age 48 years, 16 male, 16 female, 8 male. And the questions could be answered of a scale of 1 to 6. And the only thing I want to show here is actually the discomfort that the patients perceived because of the brace being felt as a foreign object, and that often is a problem. Here are the problems. Most patients saw the brace as very positive. Of course, you always have some having different factors being seen as negative. And the good thing about the brace itself is, and that is very important, we had 75 braces that did not need to be refitted. So those were the patients you didn't see again, at least the orthotist not. And here you have the different braces, customized braces versus the prefabricated TFCC. You have the Hagert, Munster braces everybody knows. Every brace has its advantages and disadvantages, some of them being also of a hygienic value, which is very important regarding the length of immobilization with the brace. And what I wanted to give you as a take-home message is the brace we use is well suited for surgical conservative therapy. It stabilizes very well. In comparison to Munster Hagert brace, the wear and comfort is definitely higher, and it has optimal possibilities of refitting, and of course, as already mentioned, the high hygienic standard that you can keep up, and different parts can be removed successively just to meet the individual needs. And of course, it also allows for an individual limitation of pronation and supination. Okay. Nice thing is the brace can be checked. It can easily be taken off and put on again, and you can do that at just about any time with not much having to be done. Okay. Thank you very much for your attention at this time of day.
Thank you very much. Some question for the audience? No. It's okay. Perfect. Thank you very much. I ask you to Dr. Margaret Falk from Hong Kong to talk about should we repair TFCC in distal radius fracture.
Good morning. Thank you, Chairman, for letting me to have this opportunity for the presentation. So as we all know, that, there's a lot of TFCC tears in distal radius fractures, and Linda already have studied for 15 years follow-up saying that we may not need to repair TFCC and they may not have the RUJ symptoms. However, nowadays we do a lot of anatomical plate fixation, and there's also a postulation that TFCC tear, especially the peripheral tear, will heal after the distal radius fracture because we do an anatomical reduction. So this is a study that we want to see whether the TFCC status after the healing of the distal radius fractures. So we have 80 patients with distal radius fractures with average age of 53 years old. And this is a distribution of the, based on the AO classification. You can see that most of them are type C fractured. And with 40 of them have ulnar styloid fracture, but 19 of them, the ulnar styloid is unhealed. 36 of them do have pain, and 50 of them do have the RUJ instability before after the healing of the distal radius fracture. And what we do is we remove those plates, and then we do a wrist arthroscopy at the same time. And when we see that there's a healing of the fractures, we find that only 16 of them have an intact TFCC. 80% of them have a TFCC tear, of which you can see that most of them do have a 1D tear. There's some partial healing of them with 25 of them, and you can see that most of them is in the 1D tear. There's no correlation of the fracture pattern and the TFCC tear. There's no correlation of TFCC tear, whether they're healed or partial or healing, or fovea only with ulnar wrist pain. There's no correlation of the complete TFCC tear and fovea tear and DRUJ instability. There's no correlation of ulnar styloid fractures, whether they're healed or unhealed, and TFCC tear. And there's no correlation of ulnar styloid fracture, healed or unhealed, and DRUJ instability and ulnar wrist pain. And then, so for the patients who have pain and have significant symptoms, we do repair them if they get deemed repairable. And so we have 16 of them intact, we didn't do anything. 32 of them we have TFCC repair, and 32 of them with no TFCC repair. And that's 1 year follow-up. You can see that actually all of them, irrespective of whether we repair them or not repair them, their pain score, the range of movement, the power, and the DASH score all improve with statistically significant. So I think this study correlates that with previous study that TFCC is common in DR fractures. However, we think that the TFCC tear and the symptoms and signs is not completely correlated with just TFCC tear as opposed to with DR fractures. We do find that 39% of the TFCC tears do heal after the distal radius fracture with plate fixation. And we noticed that improvement was noted even after the delayed repair. So the recommendation is that we only repair them when they are symptomatic, but not simultaneously at the DR with the plate fixation. So thank you.
Question from the audience? I noted, this is my question, I noted that you talk about or reported 40 cases of 1D lesion.
Yes.
It's amazing number. I never seen so much cases. Can you explain better, please?
I know. I mean, I think a lot of them do have some kind of. It is a type. We do have a significant of them have a type C AO classification based type C distal radius fractures, and I think a lot of them do have some kind of tear at the time of the fractures. So we do see them in these cases. Another thing that we cannot exclude that. Because you can see that this is an old, the average age is around 54, and this is so older age groups, so maybe they have it's difficult to exclude them whether they have any kind of pre-existing injury before that. Yes, but this is a study. Thanks.
Thank you.
Thank you.
Okay, no more question. Move on now. With Mr. Hin, Dr. Hin, that will, from China, that will talk about of arthroscopy-assisted treatment of distal radius fracture combined with TFCC injury.
Okay, thank you, Chairman. Thank you, all the audience. I'm Huawei Yin from China, and my topic is about arthroscopic-assisted treatment of distal radius fracture combined with TFCC injury. This is also about the instance of TFCC injury for the patient with distal radius fracture. And we also trying to find out how about the role of wrist arthroscopy for the distal radius fracture. I have no conflict. This is clear. The general information about as following, and the patient is 41, and we divide into two groups about acute group and chronic group. And we found that in the acute group, the incidence of TFCC injury is 52.9%. And this is a classic patient of acute distal radius fracture. And when we have the wrist arthroscopy and we assessed the radiocarpodron, and we found that the distal radius was fractured into 3 fragments, including styloid, palmar, and dorsal fragment, and also found ligament injury and TFCC injury. And we fixed it with a preliminary method, and we found that there is a step formed among the 3 fragments, and we tested the height of the step is over 2 millimeters. And then we tried the wrist arthroscopy again, and the reduced styloid fragment can be moved, but the dorsal fragment cannot be moved to correct the step. So we drilled out about half of the screw length for the fragment relocation, and we used 2 KRIs to assess the reduction of the styloid fragment and the dorsal fragment. And this is the view after the reduction of the styloid fragment and the dorsal fragment. It is almost plain. And after the fixation, we found the volatility is also corrected. And this is the central development and TFC repair. And we also used in the chronic stage, and this is the case of the chronic stage, and we found there is some tissue between the carpals and the radius. So we used some tools to take off the scar tissue, and we found that the range of motion could be improved. So the conclusion about this study is the DIF is often accommodated by the type 1 injury, and if under styloid fracture, the TFC tension is descent, but when we do the fixation with under styloid, the TFC tension could recover, and regular follow-up is needed for this kind of patient. Thank you so much.
Any question from the audience? I've seen that you are using for the arthroscopy water and not water, wet and dry. When you use water, when you don't water?
Commonly we will use with water, but if there is a fracture, we will use the dry method because maybe some the water coming into the bone. I think it's not good for the patient. Good. Thank you so much.
Okay, thank you very much. We can say that the session is concluded. Thank you for everyone, and you too.